Good, good day, everybody. My name is Hallie Prescott. I'm a pulmonary critical care physician at University of Michigan, and it's a pleasure to be speaking to you about sepsis management bundles. I have no financial conflicts of interest. I have a variety of current funding related to sepsis projects. Additionally, I serve as a physician lead for a Michigan statewide sepsis quality improvement initiative and served as vice chair of the 2021 Surviving Sepsis Campaign Guideline. I'm obliged to tell you this talk does not necessarily represent views of the U.S. government, the Department of Veteran Affairs, the Surviving Sepsis Campaign, or any other organization that I'm affiliated with. The goals of my talk today are to review core elements of sepsis recognition and management, which are broadly recommended across organization and guidelines. I've drawn mostly from the Surviving Sepsis Campaign guidelines, the Surviving Sepsis Campaign Hour 1 Bundle, the American College of Emergency Physicians DART tool, but these are treatment recommendations that are broadly recommended across organizations and across national treatment guidelines. First, what is sepsis? Sepsis is a life-threatening complication of infection that arises when the body's response to infection injures its own tissues and organs. I like to think of sepsis as a line in the sand or threshold across which the body's response to microbe is now causing collateral damage. On the far left-hand side of the spectrum, we have microbial colonization. There's a lot of microbes that live on and within us that are important for health and digestion. As we move to the right on this spectrum, the body views the microbe as a problem, and we see classical signs and symptoms of infection. These are things like tachycardia, redness, swelling, warmth. And as we continue to move across that spectrum, we get to a point where the body's response to that microbe is now causing collateral damage. And importantly, that damage can continue even after the infection is eradicated. And it is this clinical syndrome that we will be talking about today. One of the most important things to reduce the burden of sepsis is to have a high index of suspicion. The Surviving Sepsis Campaign guidelines recommend that for hospitals and health systems, that there should be screening for sepsis among acutely ill, high-risk patients. There is no specific screening tool that is recommended by the Surviving Sepsis Campaign guidelines, and the optimal tool is likely to vary depending on the location or setting or type of facility that you work at. However, the campaign does recommend against using QSOFA as opposed to other tools as a single screening tool for sepsis. And the reason for that is that QSOFA was designed to be a triage tool or a risk stratification tool to sort of rapidly identify sick patients at risk for poor outcomes. However, it is neither sensitive nor specific for sepsis, and so it is not an optimal tool to either rule in or rule out sepsis. When thinking about whether your patient has sepsis, it is important to ask this question for all patients who present to the hospital and for all patients who experience an acute worsening of their clinical symptoms. And we want to ask this from two directions. First, for patients who have signs or symptoms of infection or a known infection, we want to ask, is there infection-related acute organ dysfunction present, such that this patient then meets criteria for sepsis? And at the same time, for patients who have acute organ dysfunction, we want to ask, could this organ dysfunction be due to an infection, in which case, again, this patient would meet clinical criteria for sepsis. For patients who have sepsis or who may have sepsis, the next things that we want to do are to initiate antimicrobial therapy and an evaluation for infectious and non-infectious causes of our illness to either confirm this suspicion for infection or refute this suspicion for infection and determine the other cause potentially for their illness. So the guidelines now recommend stratifying antimicrobial timing according to two criteria. First, based on your overall clinical assessment, how likely is it that this patient has sepsis? If you believe this patient has sepsis, antimicrobials should be administered immediately, ideally within 1 hour of recognition. If sepsis is possible, but you're just getting to know this patient in the emergency department, and they're just getting admitted to the intensive care unit and you're not sure, how quickly you administer antimicrobials should be stratified based on how sick they are. So for patients who are in shock, these are patients who are too sick to guess wrong, too sick to delay therapy, the guidelines recommend administering antimicrobials immediately, ideally within 1 hour, of course continuing to look for and confirm infectious versus non-infectious causes of illness and stopping those antimicrobials promptly if they turn out to have a non-infectious or non-bacterial cause for their illness. However, for patients where sepsis is possible, the patient is not in shock, the guidelines recommend a rapid assessment of infectious versus non-infectious causes of illness with a goal to administer antimicrobials within 3 hours if after that rapid evaluation, concern for infection persists. So the sorts of things that you can do in 3 hours include collecting additional history from the patient, doing additional physical exam, collecting blood work that can be processed quickly, completing radiographic procedures such as x-rays or ultrasounds that can be completed quickly, and then using that information to increase or decrease your likelihood of infection versus other causes of illness and make a decision about whether the patient warrants antimicrobial therapy. For all patients, we recommend additional evaluations. So prior to starting antimicrobial therapy, microbiologic cultures, including blood cultures, should be obtained. For patients with infection, we recommend evaluating for source control, evaluating for a source of infection that would require anatomic source control and implementing a source control procedure as soon as feasible. Antimicrobial coverage should be tailored to patients' risk and to local resistant patterns. And then for patients with sepsis or at risk for sepsis, we recommend measuring lactate. That helps guide whether patient warrants fluid resuscitation. It's also a marker that can be followed over the course of resuscitation to assess whether patient is responding to resuscitation. The background for these stratified antimicrobial timing recommendations is that they're trying to really balance what are two larger bodies of literature at this point. On the one hand, we know that time to antibiotics matter and that association is strongest for patients who present in shock. We also know that diagnostic uncertainty is common in practice, and studies suggest that somewhere around a quarter to a third of patients who are admitted from the emergency department or admitted into an intensive care unit with a tentative diagnosis of sepsis turn out to have a non-infectious or non-bacterial cause for their illness. And so the guidelines are trying to balance these two competing issues to get treatment as soon as possible to patients with sepsis or potential sepsis who are in shock, while trying to avoid overtreatment of patients. The next thing to consider after antimicrobial therapy and a broader evaluation to confirm or refute the suspicion for infection is to initiate fluid resuscitation for patients who have hypoperfusion, either low blood pressure or an elevated blood lactate level. Triggers for fluid include low systolic blood pressure, less than 90, low mean arterial pressure, less than 65, a systolic blood pressure that is at least 40 below a known baseline in patients who are hypertensive at baseline, and then an elevated blood lactate level. Many guidelines and bundles recommend 4 as a threshold or trigger for fluid resuscitation. I tend to use 2, and that is based on a study by Vinnie Liu and colleagues at Kaiser Permanente in Northern California, where they showed a mortality benefit after initiating a sepsis resuscitation bundle in patients specifically with an intermediate lactate of 2 to 4. And so that has changed my practice to include lactate level greater than 2 as a trigger for resuscitation. All patients should be monitored closely while undergoing fluid resuscitation, but reasons to watch patients especially closely because they may have more difficulty tolerating fluid include patients with a severely reduced left ventricular ejection fraction, patients with severe or critical aortic stenosis, or patients with end-stage renal disease. The guidelines suggest that most patients will need at least 30 ml per kg, but certainly there are some patients who will need less and some patients who will need more. In general, 30 ml per kg per ideal body weight translates to about 1.5 to 2.6 liters, to give some sense of the amount of fluid volume these guidelines are mentioning. For patients who are severely obese, that fluid should likely be adjusted, and the study referenced here in Journal of Critical Care by Stephanie Taylor suggests that adjusted body weight may be the optimal approach for patients who are obese. In terms of what fluid to use, the guidelines suggest balanced crystalloids such as lactated ringers over normal saline. This recommendation was based on the SMART trial, which was a cluster randomized trial of balanced solutions versus saline that showed two things. First, it's feasible to give patients majority balanced fluids. And second, it's associated with a mortality benefit in patients with sepsis. A secondary analysis of the same trial showed that the effect of balanced crystalloids versus saline was greatest if that fluid was started, if the fluid in the emergency department or the initial part of the resuscitation was also done in balanced fluids. This suggests that it's best to use balanced fluids from the beginning, as opposed to maybe starting with saline but converting over to balanced solution in the event that the patient gets hyperchloremic. Since the guidelines were published, there's been a number of other studies or sort of additional data that's come out on this topic. The BASICS trial was a clinical trial that randomized patients to balanced solutions versus saline across 75 intensive care units in Brazil. So important to recognize that fluid was randomized at the time of admission to ICU, but not in the emergency department, where perhaps the bulk of the fluid resuscitation for community onset sepsis was likely to have occurred. However, the investigators for that trial did a secondary analysis where they looked specifically at patients who were admitted to the emergency department with sepsis and treated with balanced solutions in the emergency department. And this secondary analysis found that there was a 96% probability of mortality benefit with balanced solutions for patients with sepsis who had been initiated on balanced solutions from the emergency department. Finally, there was an NEJM evidence meta-analysis. This included 13 trials, nearly 36,000 patients, nearly 7,000 of whom had sepsis, and showed that overall, in critically ill patient population, there's a 90% probability that balanced fluids confer a mortality benefit, and we know from prior studies that this effect is likely stronger in patients with sepsis. So there's been lots of evidence on this topic, and the sum total of the evidence suggests that balanced solutions likely provide a mortality benefit in patients with sepsis. In addition to the volume and the type of fluid, the guidelines make a number of recommendations regarding monitoring of patients. They suggest using dynamic rather than static measures to assess responsiveness to fluid. They suggest guiding resuscitation to decrease serum lactate in patient who had an elevated serum lactate. And they suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. I think these all speak to the broader topic of it is important to monitor patients throughout the resuscitation to ensure that they are getting better or responding to the antimicrobials and resuscitation that is being provided. For patients who are not showing clinical signs of improvement, we always want to ask whether the treatment and the diagnosis are correct. Is the antimicrobial coverage appropriate? Has source control been adequately addressed? Are there other contributing diagnoses? The next thing we want to consider for patients who are severely hypotensive or non-responsive to initial fluids is to initiate norepinephrine to target a mean arterial pressure. The Surviving Sepsis Campaign guidelines recommend targeting a mean arterial pressure greater than 65. The 65 trial suggests that a mean arterial pressure of 60 may be sufficient in older patients. And so I have suggested here to target a mean arterial pressure of 60 to 65. The guidelines suggest starting vasopressors peripherally to restore mean arterial pressure quickly, rather than delaying initiation until a central venous catheter can be placed. And this new suggestion comes from a variety of studies that suggest there's a low complication rate to peripheral vasopressor administration, that it facilitates faster time to resolution of shock, and that makes sense because it requires some time to place the central line, and that for some patients who require vasopressors for only a short period of time, it may avoid central line placement and associated complications altogether. However, the guidelines still include a comment or a remark that as soon as feasible, central access should be obtained and vasopressors then delivered through that route. It's important to remember when delivering vasopressors through a peripheral IV that all of the studies suggesting safety were all done in the setting of sort of policies or protocols that ensured that these were high quality peripheral IVs and that the peripheral IV was being monitored. So here, this table shows the summary of requirements for peripheral venous access used for infusion of vasopressors in the largest prospective study of about 700 patients who had peripheral vasopressor administration. So the vein had to be sufficiently large, greater than 4 millimeters by ultrasound. It had to be documented as being placed into the vein by ultrasound. It could be in the upper extremity only, contralateral to the blood pressure cuff. It had to be sufficiently large, 18 or 20 gauge, no 22 or 24 gauge. It could not be placed into the hand, wrist, or antecubital fossa, where the patient, of course, may move, and that may make it more prone to being dislodged and having vasopressor extravasation and associated tissue injury. They had to be monitored, so there had to be blood return prior to initiating the vasopressor, and the IV had to be assessed every 2 hours per a nursing protocol. There was an immediate alert to the medical team in the event of extravasation with prompt initiation of local treatment. And when the study was published, the hospital also had a 72-hour hard cap in terms of the duration of peripheral IV access. I think increasingly it's unclear whether there needs to be a hard cap for duration of peripheral IV, but certainly for patients who have escalating doses of norepinephrine, such as greater than 2 micrograms per kg per minute, or who are clinically worsening, it would make sense to place a central line and transfer vasopressor administration to central access. So what next? After the patient has had antimicrobials, you've initiated your evaluation, fluid resuscitation, vasopressor initiation. There is a number of recommendations in the guideline to tailor ongoing therapy. For patients who continue to require vasopressors, the guidelines suggest initiation of IV corticosteroids. Typically, this would be 50 Q6 of hydrocortisone. And the idea here is to reduce duration of shock, which has been shown consistently in recent high-quality systematic reviews and meta-analysis for patients initiated on IV hydrocortisone. Second, for patients on norepinephrine with escalating doses, the guidelines suggest adding vasopressin as opposed to continuing to escalate the dose of norepinephrine. The idea here is to spare or reduce the total dose of catecholamine vasopressor infusion. And then finally, continuing to reassess the patient day by day to assess for de-escalation or stopping of antimicrobial therapies, as we have strong data that shorter durations are generally safe, effective, and spare complications associated with long-term broad-spectrum antimicrobial coverage. For patients who are not getting better, we always want to be reassessing. Is the antimicrobial coverage appropriate? Has source control been adequately addressed? Is this diagnosis of sepsis correct? So in summary, we want to be always asking, could this be sepsis for all patients who present with signs or symptoms of infection or undifferentiated critical illness? We want to evaluate for infectious versus non-infectious causes and clarify the site and etiology of infection. Our initial evaluation should include lactate measurement, microbial cultures, including blood cultures, and assessment of source control. Antimicrobial therapy should be started as soon as possible in patients who have sepsis, who are likely to have sepsis, or who have undifferentiated shock that may be due to sepsis. Antimicrobial therapy should be tailored to patients' risk factors and to the local epidemiology of the likely causes of infection and resistance patterns. Fluid resuscitation for patients should occur if they are hypotensive or have an elevated blood lactate level. Typically, this is 500 to 1,000 mLs of balanced solutions every 15 to 30 minutes while monitoring patients' clinical response to resuscitation. Many, but not all patients will need around 30 mLs per kg of fluid. Norepinephrine should be started for patients who are severely hypotensive or those who remain hypotensive after the initial fluid administration. It is okay to initiate vasopressors through a high-quality peripheral catheter with regular monitoring, but central access should be obtained for patients with persistent or escalating vasopressor dose. I would like to thank you all for listening. It's been a pleasure to talk today. Take care.